physical activity, dietary patterns and body composition influence cancer prevention and control. His methodological expertise is in the design and conduct of randomized controlled trials and cohort studies. He has served as principal investigators of 2 National Cancer Institute-sponsored clinical studies investigating the role of exercise and lifestyle modification in cancer survivors. Dr. Brown has published over 45 first-authored, peer-reviewed papers in leading scientific journals, such as the Journal of Clinical Oncology and the Journal of the National Cancer Institute. In 2013, he received the Citation Award for authoring the most frequently cited paper in cancer epidemiology and biomarkers and prevention. In May of 2017, he received the inaugural National Institutes of Health Office of Disease Prevention Early Stage Investigator Award, which recognized him as the #1 early stage disease prevention scientist in the United States. He has presented invited lectures on the role of lifestyle modification for cancer prevention and control across the United States, and his research has been featured in several major news outlets. Dr. Brown received his PhD in clinical epidemiology from the University of Pennsylvania Perelman School of Medicine in 2016, and his master's degree in kinesiology from the University of Connecticut in 2011. Please join me in welcoming Dr. Brown.
So this is the first conference that I've been to that we're actually ahead of schedule. And I've been given the instruction that I cannot start providing scientific contact until 9 o'clock. So I want to thank Jill for the kind introduction. I want to thank Sam for the invitation. I think this type of program is really important because, as Sam said, we have national meetings where you have to get on an airplane or have to actually leave the country in order to get up to date on what the cutting edge science is in clinical exercise physiology, and being able to really bring the science to the practitioners in their own state or in their own town, I think it really truly is innovative and ultimately will help to advance the field. So I'll share a personal story. A lot of people ask how I got into studying exercise in cancer. And I'll tell you that what I study really goes beyond exercise. It relates to energy balance more broadly, which includes physical activity. That's one aspect of energy balance, but also diet, what we eat as calories in, and the difference between those things, which is body composition or our stored energy. And so the reason I do this is I was an exercise physiology undergrad. I went to Eastern Connecticut State, where Jill graduated from as well. It was my junior year, and I went to my advisor and I said, Dr. Charlie Chatterton, who many of you probably know, and I said, Dr. Chatterton, what am I going to do when I graduate? I haven't really thought much about getting a job and what I'm going to do. And he was the one that actually recommended thinking about going to graduate school. So I tell the story that honestly, I kind of fell ass backwards into graduate school, and I ended up spending 11 years in college, which I never would have envisioned, because when I was in high school, I wanted to be a union carpenter in New York City. I had no intent on going to college. And then we started getting college letters, and my mom was the one that kind of encouraged me going to college. My dad wasn't around at the time, so when I was 14, my father passed away from colorectal cancer. He died on our front porch, and I really felt powerless at that time. And it was having that conversation with Dr. Chatterton where I realized that my expertise in exercise physiology may be able to help cancer patients, may be able to help them live longer, healthier lives. And I now had this scientific expertise, this tool that I could potentially bring into the field of oncology. And so from that moment, I've never really looked back, and I've been now doing this work for almost a decade. Time really flies when you enjoy and you love what you do. And so here I am, and it really is a privilege to talk to you about the science of exercise oncology. So it is 9 o'clock, and it looks like I got the thumbs up to go. Okay, so I have no disclosures. So hopefully by the end of my talk, which is going to be about 40 minutes or so, so we have a sufficient amount of time for questions and answers, you'll be able to identify the common toxicities that occur from cancer therapy and be able to describe their influence in how we design exercise prescriptions. Hopefully you'll be able to summarize the physiological as well as the psychosocial or patient-reported benefits of exercise for cancer patients. And ultimately, at the end of the day, you guys all are practitioners. And I want you to be able to have at least the beginning of an understanding of how to design and prescribe safe and evidence-based exercise programs for cancer patients. So this is a helpful framework to think about the oncology continuum. And there's really two major components. The first is the pre-diagnosis phase, which is everything leading up to the point of being diagnosed with cancer. And the second major phase is post-diagnosis. So from the time you're told you have cancer until you pass away from whether it's cancer or some other competing cause. I'm going to spend one slide talking about pre-diagnosis and the benefits of exercise or physical activity for cancer prevention, but the bulk of my talk is going to be designing exercise programs for cancer patients. That is, patients who have a cancer active and are being actively treated or have been treated in the past for a cancer. So there are hundreds of observational studies that link participation in physical activity with a lower risk of developing multiple different types of cancer. So the study that I cite here was a pooled analysis of 12 different studies. It included about 1.4 million adults, and the adults self-reported their physical activity. And then they were followed over time until some of them developed different types of cancer. When you compare those who reported the most physical activity to those who reported very little physical activity, those who are most physically active were anywhere from 10 to 42% less likely to develop a variety of different cancers. So the most common cancers include those of the gastrointestinal tract, including esophageal or gastric cancer, that's cancer of the stomach, liver cancer, colon and rectal cancer, several female cancers, including breast and endometrial cancer, cancers of the head and neck, cancers of the lung, genitourinary cancers, including kidney and bladder cancer, as well as multiple hematologic malignancies, which are cancers of the blood or bone marrow, including myeloid leukemia and multiple myeloma. So I tell you this because this, although this data is observational, we don't have cause and effect, we just have association, it provides further evidence that healthy adults should be engaging in physical activity, and this is just more evidence to underscore the importance of engaging in a healthy lifestyle for the purposes of primary cancer prevention, that is, preventing cancer from developing in the first place. So now I want to move on to patients who actually have been told they have a cancer. Each year there's about 1.7 million adults that are told you have a cancer. It's split about 50-50 between males and females. And here I've listed the most common cancer types. And consequently, these are going to be probably the most common cancer patients that you're going to interact with simply because they're common cancers. So among men, about 1 in 5 new diagnoses is of prostate cancer, followed by lung cancer and then colon and rectal cancer. Among women, about 1 in 3 new cancers will be a breast cancer. And then very much like men, the second and third most common are lung as well as colon and rectal cancer. And just to remind people, cancer is really a disease of aging. And if we live long enough, many of us will develop a cancer. So the lifetime risk for the men in the room of developing cancer is about 1 in 2. And for the women in the room, it's 1 in 3. So cancer is a very common disease. One of the ways we characterize success in the field of oncology is the proportion of patients who live 5 or more years after a diagnosis of cancer. That's really thought to be one of the gold standard outcomes for success in oncology. And if you were diagnosed with cancer in the year 1979, about 49% of adults would live 5 or more years. 51% of them, the majority of them, would die before they got to the landmark date of 5 years. If you speed ahead 3 decades, If you were diagnosed with cancer in 2008, that proportion is now up to 69%. And we are getting very close to our Healthy People 2020 goal, which is 72%. I do want to acknowledge that these are the averages for a variety of different cancers, and there is extreme variation between cancers depending on where they are anatomically in the body, as well as the stage or how far they have progressed in their clinical course. So for example, early stage breast, colon, rectal, and prostate cancer have 5-year survivals that exceed 90%. Many patients do very well. Conversely, advanced or metastatic cancers of the pancreas or the ovary or lung, so 5-year survival is often in the single digits. It's often much less than 10%. But nevertheless, over time, we have gotten much better at keeping patients alive for longer. And the result is really for 2 reasons. The first is we're doing more screening. So we're screening for breast cancer with mammography. We're screening for colorectal cancer with colonoscopy. Some providers now are doing low-dose CT scanning for lung cancer. So that's one thing. We're detecting more cancers, and we're detecting them earlier in their disease course, so we can actually intervene and potentially cure them of their disease. And on the other end of the spectrum, we have more therapies to treat patients. So many cancer patients are treated with what we call multimodality therapy, which is may include surgery. Many patients will get surgery if you have a solid tumor. Patients will also may get chemotherapy or radiation. Some patients, depending on your tumor characteristics, will get hormone or endocrine therapy, as well as probably what you guys hear about a lot on the news now, immunotherapy, where we can actually use the patient's immune system to treat their own cancer. So the bottom line here is we're doing better at keeping patients alive for longer. And as a result, there are more people living with a history of cancer. So in 1975, there was 3.6 million people who had a history of cancer. In 2016, that number increased to 15.1 million. In 2040, it's expected that there will be 26.1 million people living in the United States with a history of cancer. And this is really the consequence of the aging of the baby boomer population. And so I want you to recognize that about 75% of adult cancer patients are over the age of 65. Like I said, cancer is a disease of aging. And so from an exercise prescription point of view, not only do these patients have a history of cancer, but they also have comorbidities that tend to accumulate with age. Things like type 2 diabetes, the metabolic syndrome, coronary artery disease, arthritis, etc. Okay, so we have a growing population of people who are living with a history of cancer. So that's a lot of the good news. The challenge is a lot of the therapies that we use to treat and cure people of their cancer are plagued with side effects. So nearly every therapy that we use to treat somebody for cancer has some impact on nearly every organ system that we have in the body. And you can think of these different side effects along a continuum. So there are acute side effects that often happen during treatment. A lot of times you'll think characteristically of when patients get chemotherapy, often they have nausea, they have vomiting, they have constipation, and often once the therapy is done, those side effects tend to go away. Those are acute side effects. There are also chronic side effects, things like that develop during treatment, and then after treatment's done, they tend to persist. Sometimes for patients they go away, but for many patients they persist. So for example, a lot of patients develop fatigue during therapy, but once the treatment stops, they remain chronically fatigued. Another good example is neuropathy, the tingling in the fingers and toes that results from some of the chemotherapy agents we use to treat patients. It develops during therapy, but once therapy is done, a lot of times patients report that the neuropathy persists. And then there are other side effects at the other end of the continuum that are called late side effects. So these side effects don't develop during therapy, but they may develop years or even decades down the road. So there are some therapies we use that actually cause congestive heart failure. So we take care of the cancer, but we cause you to have cardiovascular disease. Another example is some people will develop lymphedema, which is a swelling of either the arm or the leg as a result of having surgical excision or irradiation of lymph nodes. And so this may happen a year after therapy. It may never happen. It may happen 2 or 3 decades down the road. And so there are a variety of different toxicities that occur from cancer treatment, and I can't list them all. I only have an hour to talk, but I will tell you that many patients will have a variety of side effects, and every patient will have a unique constellation of symptoms. Even if they are the same age, treated for the same cancer, with the same therapies, they will have different side effects that you're going to have to learn how to adapt their exercise program as a result of some of these toxicities or side effects. So what's nice is there are exercise prescription guidelines specific for cancer patients. And what's beautiful is they're the same exercise prescription guidelines that we recommend for healthy adults in the United States. So if there are 8 words that you leave from my talk with, it is these 8 words. Patients with cancer need to sit less, they need to be active, they need to build strength, and they need to improve balance. Okay, those are the 8 words that you need to be telling patients. And so in the next couple slides, I'll describe each of these things in greater detail. But basically, this slide summarizes exactly what the 2008 and the 2018 Department of Health and Human Services guidelines, physical activity recommendations for all Americans suggest. It's the same thing. Cancer is no different. So number 1 is sit less. The first words of the American College of Sports Medicine recommendations for cancer survivors is that patients avoid inactivity. We are a very sedentary population now, and so patients should avoid inactivity even if they have existing disease. That is, patients with metastatic cancer, where cancer spread to distant parts of the body, they should avoid inactivity, as well as patients who are undergoing difficult treatments. And it seems like every day there are studies emerging highlighting the deleterious effect that sedentary behavior has on various health outcomes. So I want you to think, most cancer patients get surgery, and after surgery, they often lay in a bed, sometimes for a week, sometimes even more. And there are now randomized clinical trials that show that early ambulation, just getting patients up out of bed and having them walk around, for example, after a colon and rectal surgery, can actually shave time off their length of stay. And I don't know a patient that wants to stay longer in the hospital than they have to. So you should encourage patients to avoid inactivity. Number 2, patients should be active. And just like we tell older adults and basically everybody in this room, patients should strive to accumulate 150 minutes per week of moderate intensity aerobic activity or 75 minutes per week of vigorous intensity activity. And when I counsel patients in clinic, I tell them to find an activity that they like to do because I want them to do it for the rest of their lives. I don't want them to stop. If patients want to accumulate more health benefits, I encourage them to go beyond these recommendations up to about 300 minutes per week. So we know that higher volumes of aerobic exercise are beneficial for either the prevention of weight gain or the maintenance of weight loss. And so I tell people this is really what you should be trying to do. If you want to do more, you are more than welcome to do so. Number 3, build strength. Patients with cancer are encouraged to try to do 2 days per week of muscle strengthening exercise. Like I said, cancer is a disease of aging. Many patients with cancer are over the age of 65. That means many of them will have sarcopenia, low muscle mass. They will have dynapenia, low muscle strength. And so by having them engage in muscle strengthening activities, at a minimum, it can help retard the rate at which muscle mass and muscle strength are lost. And number 4, improve balance. So patients should be engaged, should be encouraged to participate in balance activities and neuromuscular activities. Again, as we age, we tend to lose some of our proprioception. If you take that older adult who has potentially a little bit compromised balance, and then you treat them for cancer, it often accelerates the loss of their proprioceptive ability. Imagine not being able to feel the bottoms of your feet from some of the chemotherapies that we give people. So patients should be encouraged to engage in neuromuscular and balance activities because we know that having poor balance increases your likelihood for having a fall, and if you have a fall, you're likely to have an injurious fracture that puts you back in the hospital for many more weeks, and we just have this vicious cycle. So trying to prevent the deterioration is really critical. So we prescribe exercise really like we prescribe pharmacotherapy, like we prescribe medications or drugs to patients. And we use the FIT-VP principle, which many of you are probably familiar with. For those of you who don't know, the FIT-VP principle really describes the exercise prescription program variables that we can manipulate in order to achieve a desired health outcome. So FIT-VP stands for frequency, or how often, intensity, or how hard, time, or how long, type, or what kind, what modality, volume is how much, progression is how soon. And I often add an S, so it's FIT VPs, because in cancer, there may be a subset of the population that would benefit from supervision or with whom, either because they have very significant comorbid health conditions that complicate the prescription of exercise, but I'll also show you data where supervision may actually modify some of the benefits, such that supervised exercise gets you larger health benefits than unsupervised exercise. So the challenge in oncology is we don't have a lot of good data to tell us what variables we want to tailor. So I'm going to describe some of the data that exists in oncology, but often we rely on clinical trials in older adults, and unfortunately there are situations where we have no data and we just have to use our expert opinion. And that's really what I think of as the art of exercise prescription, where you have some data points from randomized trials for efficacy, but the reality is you have a patient sitting in front of you here and now, and you need to make decisions for that patient. So my hope is that, in the next part of my talk, I'll be able to provide you with what some of the efficacy randomized trials show, but it's really going to be up to you to use your expertise to figure out what you want to manipulate in order to make sure that that participant or that patient can exercise safely and is working towards the desired health outcome that you and that person have agreed upon. So I have good news and bad news. The bad news is many cancer patients are physically inactive. Less than 10% engage in regular physical activity. So this is data measured using an accelerometer from the National Health and Nutrition Examination Survey. This is NHANES. So NHANES is thought to be a population-based survey that is broadly representative of everyone, or most people living in the United States. So it is likely that many patients that you counsel who have had cancer, it is the first time in their life that you are telling them, you're talking to them about exercising for the sole purpose of deriving health benefits. So that's the bad news. The good news is we have an amazing opportunity to help these people. We have so much room to improve until we get to the ceiling, until we get to the point where everybody is physically active. So the reality is many patients are physically inactive. They were inactive before they were diagnosed with cancer, and they're inactive now. There is a subset of people who were very physically active before, and the diagnosis of the cancer really just kind of threw off their schedule and understandably was a distraction, and you just want to help those people get back on track. And I'll talk about how to handle those people at the end of my talk. So exercise oncology is an exploding field. This was a PubMed search that I conducted about a week ago using the terms exercise and oncology and randomized. And you can see that there has been an exponential increase in the number of studies published each year. Last year in 2017, there was nearly 300 studies published investigating the effects of exercise in some type of cancer population. So the data is rapidly emerging, and the field is constantly changing based on new findings and new conclusions from these randomized controlled trials. So now I want to talk about the benefits of exercise, the established benefits of exercise. And when I say established, I mean that there are meta-analyses of randomized controlled trials supporting the observed benefits of prescribing exercise to this population. And I've really split this section into two parts: the physiological benefits of exercise and then the psychosocial or patient-reported benefits of exercise. So the physiological benefits of exercise. We know that exercise training increases cardiovascular fitness, exercise training increases muscle strength, exercise training increases muscle size, and exercise training decreases adiposity. Okay, so in the next couple slides, I'm going to walk you through each of these to really show you the magnitude of benefit that's observed in patients with cancer when they engage in exercise. So this was a meta-analysis of 48 randomized trials. It included about 3,600 patients, mostly breast cancer, both during their therapy, which is often radiation and chemotherapy, but also after they have finished their therapy. And the primary exercise modality that was investigated in this meta-analysis was aerobic exercise or aerobic plus some other modality, often resistance exercise. And you can see that among all of the studies, among all 48 studies, there was a statistically significant improvement in VO2 peak measured in milliliters of oxygen per kilogram per minute in the order of about 2.1 mils per kg per minute. The study also investigated different moderators, so different characteristics that may explain why some studies saw bigger effects and why some studies saw smaller effects. So there's really no difference between programs that just prescribe aerobic versus those that prescribe aerobic and resistance with respect to improving VO2 peak. There was some difference in the magnitude of benefit, whether the exercise program was conducted during treatment, so during chemotherapy or during radiation, or after treatment. Both settings showed statistically significant improvement in peak VO2, but the effects were a little bit larger after treatment. And I potentially explain that as being related to exercise adherence. So a lot of patients during therapy may have difficulty adhering to exercise because of the different side effects that may complicate being able to engage in aerobic exercise. So exercise training also increases muscle strength. So this was a meta-analysis of 11 studies that included about 1,200 patients. And here the primary exercise modality was strength training or strength training plus some other modality, again, often aerobic exercise. And the primary endpoint for this meta-analysis was changes in percent or changes in 1 repetition maximum. So most of these studies measured 1 RM using a typical strength test, where you press weight 1 time. Others used a submaximal test where you might press weight 5 times and then you predict the 1 RM. And what this study concluded was that exercise training increases strength of the lower limbs, of the legs, by about 14.6 kilograms, as well as, although as we would expect much smaller, increases 1 RM strength of the upper limbs in the order of about 6.9 kilograms. And there was a substantial amount of variation around these estimates, which is depicted by the I-squared statistic. So I-squared ranges from 0 to 100. The higher the value, the more variation there is between studies. And so a lot of the variation in these estimates is explained by the frequency of exercise, the intensity, so the percent 1 RM that was prescribed, as well as the exercise modality. Patients who train on resistance exercise machines tend to have a little bit bigger benefit than those who use free weights. Exercise training also improves body composition. So we know that exercise training reduces body fat and increases lean mass. This was the same meta-analysis that I just described. Again, 11 studies, about 1,200 patients. And body composition here was often measured using DEXA, which is dual energy X-ray absorptiometry. And what you can see is that exercise training decreased body fat by about 2%, and it increased lean mass by about 1 kilogram. And so, and I have on the center of this graph, there's often no change that we see in body mass with exercise alone. And I bring this point up because when I counsel patients, many of them use body mass, the weight on the bathroom scale, as an indicator for how successful their exercise program is going. And so I tell patients up front that it is unlikely that your weight on the bathroom scale is going to change because you're likely losing fat and gaining muscle. So I address this issue head on up front with patients because often if I don't, they'll say, well, I'm not losing weight. I don't really think the exercise is working. I think I'm going to stop. Okay, so I talk about it up front that there are likely changes happening that are not reflected in the bathroom scale, and that we need to think beyond just their weight and really the distribution of their tissue. And this was recapitulated with aerobic exercise, a trial that I led, where we showed that patients decreased visceral adiposity, so fat that's deep in the abdominal cavity. They increased muscle mass of their legs, but there was no change in body mass. Okay, really, I think if you want to lose weight, you need to restrict calories. Exercise is good for prevention of weight gain and maintenance of weight loss. There are also other emerging physiological benefits of exercise training that there's just not enough studies to put in a meta-analysis yet. So we know that exercise training increases physical functioning, reflected by the 6-minute walk as well as gait speed. These are important because these measures are prognostic of disability, nursing home admissions, falls, and mortality. We know that exercise, particularly strength training, resistance exercise, has a subtle osteogenic effect. It often doesn't increase bone mineral density, but what it can do is it can retard the rate at which bone mineral density is lost. And many of the agents that we use to treat patients with cancer really cause accelerated bone loss. There's some data that exercise, aerobic exercise combined with strength training reduces arthralgias or musculoskeletal symptoms that are very common with some of the endocrine therapies that we use to treat women with breast cancer. And this is really important because for endocrine therapy, we have women go on these treatments for 5 or 10 years. And we have them go on for so long because they work. They prevent the breast cancer from coming back and keep women alive for longer. But when you're on a therapy for that long a time, even having mild side effects such as the musculoskeletal symptoms is often enough for people to say, I don't want to take the drug anymore because I just feel terrible and I'm not going to do this for another decade. So the use of exercise can actually be very helpful to either reduce the severity of symptoms or prevent the symptoms from occurring in the first place. And there's also emerging data that strength training, weightlifting, is beneficial for the prevention of the development of lymphedema, again, the arm swelling. And this data is particularly applicable for upper extremity lymphedema for women with breast cancer. So strength training prevents the onset of lymphedema, prevents it from developing. And it also, among women who have established lymphedema, it doesn't seem to make the lymphedema worse. Slowly progressive resistance exercise appears to be safe for women at risk as well as with breast cancer-related lymphedema. Okay, so now I want to talk about the psychosocial patient-reported benefits of exercise. Again, supported with established evidence being meta-analyses of randomized controlled trials. We know that exercise training decreases cancer-related fatigue, exercise training increases quality of life, and exercise training decreases depressive symptoms. And I just want to take a moment to say that over the past 5 years or so, we've really started to understand more of the physiology that underlies a lot of these patient-reported or psychosocial outcomes. So for example, for women with breast cancer who get chemotherapy, many of them complain about mild cognitive impairment. And we know that using functional MRI, where we put people in a scanner and ask them to do different tests, that chemotherapy actually induces changes in brain structure that are consistent with some women reporting mild cognitive complaints. There's also data supporting, again, in breast cancer, that women who have variations in genes that are associated with inflammation are more prone or more susceptible to develop cancer-related fatigue. And so I talk about the physiology because often in oncology, patient-reported outcomes are often viewed as a little bit more squishy than a lot of the other outcomes. But there is clearly emerging evidence to support that there's a physiologic basis to explain why a lot of patients feel the way they do. Okay, so exercise training reduces cancer-related fatigue. Cancer-related fatigue is experienced by over 90% of patients during their cancer treatment, and I would say 30 to 50% of patients, even after they finish their treatment, still report some degree of fatigue that interferes with their quality of life. And there's really 3 major classes of interventions that we use to treat cancer-related fatigue. The first is pharmacotherapy or medication, and often these are central nervous system stimulants, things like methylphenidate or Ritalin, that have been suggested to have a little bit of efficacy. The other intervention is psychotherapy, so seeing a psychologist. And the third is exercise. So this was a meta-analysis of 113 studies looking at these different interventions. And what you can see is that pharmacotherapy produced a very small effect on reducing cancer-related fatigue. Psychotherapy as well as exercise both had they were small, but they were statistically significant reductions in cancer-related fatigue. So on the x-axis here is the standardized weighted mean difference. And we often think at a mean difference of 0.5 is something that a patient can actually feel and experience. So these effects are smaller than 0.5, but they're the best that we have. And I present the psychotherapy data here because I want you guys to understand what resources are around you. And if a patient provides cancer-related fatigue as an insurmountable barrier to starting exercise, then you should say, maybe I can refer them to psychotherapy so that once their fatigue starts to improve, I can have them exercise. So it's not about necessarily trying to treat everything with exercise, but knowing what resources exist. So another example that I'll give regarding the arthralgia, the musculoskeletal symptoms. When I counsel patients in clinic, some will say, I can't even walk. You want me to go exercise? And I'm not doing that. There are data to suggest that acupuncture may actually help resolve some of those symptoms. So what I do is I refer them to the acupuncturist. They get a couple sessions, they start to feel better, and then I prescribe them exercise. So it's trying to figure out how to use a toolbox of modalities in order to orient patients on a trajectory so that they start feeling better and you're able to motivate them to exercise. Exercise training improves quality of life, overall quality of life. So this wasn't a meta-analysis, but this was a pooled analysis of 34 randomized trials of individual patient-level data that included about 4,500 patients. It included aerobic exercise, resistance exercise, all different modalities. The overall benefit of exercise was statistically significant, but again, very, very small. And this is where supervision may come into effect. So this study concluded that unsupervised exercise had no significant impact on quality of life, whereas supervised exercise had a small but statistically significant effect on quality of life. Okay, and this study also investigated the fit characteristics, frequency, intensity, time, type. It did not see those characteristics, did not really modify the magnitude of benefit in response to an exercise intervention with respect to quality of life. And we know that exercise training reduces depressive symptoms. So there's a lot of patients with cancer who have really this subclinical, they don't have frank depression, but they have symptoms that are consistent with depression. And we know that exercise, this was a meta-analysis of 40 studies that included about 2,900 patients with solid tumors and hematologic malignancies, both during as well as after their treatment. Exercise had a very small effect on reducing depressive symptoms. It was significant. But more importantly, there was a dose-response relationship that was identified between volume of aerobic exercise and the magnitude of benefit observed in terms of reducing depressive symptoms. So 90 minutes of aerobic exercise per week really offered no benefit in terms of reducing depressive symptoms, but in the order of about 180 minutes per week, you can see that the effect was about 0.6, which is starting to get closer beyond that 0.5 threshold of what a patient could actually feel. So higher volumes of aerobic exercise were associated with larger reductions in depressive symptoms. And this study also identified supervision as another moderating factor, where supervised exercise, it was observed that had larger reductions in depressive symptoms versus unsupervised exercise. So there are also other emerging psychosocial patient-reported benefits of exercise training. Exercise training may reduce anxiety, may reduce sleep dysfunction, can improve body image, particularly in women with either breast cancer or different gynecologic cancers. It can improve sexual health, can reduce hot flashes, can reduce, or it can improve bowel function and may reduce pain, kind of low-level pain. So coming back to the FIT VPs, we have a little bit of understanding about what exercise program variables we can manipulate to achieve a desired health outcome. But by and large, we don't have comprehensive answers to say, if this is your problem, this is exactly what I'm going to prescribe. So what I just described was the data that was most reliable in oncology. And now it's really up to you guys to pull the data and the understanding that I just offered and integrate that with your understanding of exercise prescription for healthy older adults and maybe other chronic populations with chronic illness, and begin to practice the art of medicine, where we don't have necessarily a right answer for the patient in front of us, but we have some efficacy landmarks to help guide our decision making in order to get a patient, again, on a trajectory for being able to manage a lot of the health challenges that they may have. So this was a study that asked patients with cancer about their most common concerns. And these concerns are collapsed over a variety of different types of cancers. The top 5 concerns were fearful that my illness will return. Number 2 was concern about relapse. Number 3 was fatigue or loss of strength. Number 4 was fears about the future. And number 5 was difficulty with long-term plans. So I'll argue that 1, 2, 4, and 5 all relate to really one thing. It's the clinical event of the cancer coming back and ultimately killing that person. That's what cancer patients are terrified of. They will do whatever they have to do to prevent that cancer from coming back. So you are always going to get the question, will this do anything to prevent my cancer from coming back? The answer that I have for you today is it may, but we don't know for certain. So there are observational studies that suggest that higher volumes of physical activity may be associated with a lower risk of recurrence and mortality. This was probably the best conducted observational study. So recognize observational studies provide association, they do not provide cause and effect. Okay, so this was a study that assessed physical activity in patients who had finished treatment for early stage colon cancer. And then they were followed over time until some patients had their cancer come back and some patients passed away. What you can see is that compared to patients who walked less than 5 hours per week after their diagnosis, that's the gold line, those who walked 5 or more hours per week, the blue line, had a significant lower risk of experiencing relapse or mortality. In oncology, that's a composite endpoint called disease-free survival, or DFS, okay? And the magnitude of benefit here is not trivial. So on a relative scale, it's about a 43% reduction. On an absolute scale, it's about 9.5% at 3 years, okay? And this is independent of demographic, other behavioral factors, as well as treatment-related factors, so characteristics of the tumor. So this was the first study that really started to change our thinking about how we can use exercise or physical activity as a tool in the treatment of cancer. It's not going to replace chemotherapy or radiation or surgery, but it could be used as an additional adjunct to try to position patients to have good outcomes. So in the decade, there have been probably over a dozen other observational studies, again, association, not cause and effect, that support the relationship between higher volumes of physical activity and either a lower risk of having your cancer come back or a lower risk of dying from that cancer. There are established data for breast cancer, colon cancer, as well as prostate cancer. And the magnitude of benefit comparing the most physically active to the least physically active is about a 37% relative risk reduction in the risk of dying from cancer. There are also emerging data from ovarian cancer. So one of the major kind of hot topics in exercise oncology is what are the physiologic mediators that link physical activity with clinical events, recurrence and death in patients with cancer. And it really relates to a lot of the prevailing hypotheses relate to one of 5 things. So that's the effects of exercise or physical activity on immune function, on inflammation, on adiposity, on insulin and other insulin-like growth factors, as well as adipokines, things like leptin and adiponectin that are often secreted from adipose tissue. This is a very hot area in oncology. And one of the challenges with studying physical activity is, unlike a drug, it doesn't act through a single pathway. It acts likely through multiple pathways. So it's unlikely that any of these one single things explains the relationship between exercise or physical activity with a recurrence or survival benefit, but it's likely a constellation of different mechanisms acting in harmony that the clinical result is a lower risk of recurrence and death. And there are ongoing randomized phase 3 trials. So phase 3 trials study disease endpoints, either death or relapse from cancer. So the top, and both of these are methods papers that describe the study. They don't describe the results. The top paper is the Colon Health and Lifelong Exercise Change Trial, or the Challenge Trial. This study is being led out of Canada, and it will randomize patients who have been treated for early colon cancer to a 3-year physical activity program or a health education control arm. The primary endpoint is disease-free survival. The other paper here is the intense exercise for survival among men with metastatic castrate prostate cancer, the interval GAP4 trial. It's being led out of Australia. And this study takes men with advanced prostate cancer and randomizes them to an exercise program that includes aerobic exercise as well as resistance training compared to a usual care group. And the primary endpoint for this trial is overall survival. So when we study clinical events, they're much less common than other things that we study. And so the sample sizes for these trials are quite large. Each of these studies is about 1,000 participants. And the hope is that if these studies are positive, if they show that there's a benefit, it will provide a very strong foundation of evidence to integrate exercise into the standard of care for oncology because it has a proven survival benefit. So these studies will, they're continuing to accrue, but it takes many, many years in order for these studies to be completed. Okay, so the second to last thing I want to discuss is risk assessment for exercise-induced adverse events. So there's very little data in oncology about who's at risk for having bad outcomes from exercise training, primarily because randomized trials very selectively recruit participants into who can enroll and who can't. In clinical practice, we don't have the luxury of selecting who our patients are. And so a lot of this comes down to expert opinion. And so this was the risk stratification schema that was developed by the expert panel at the National Comprehensive Cancer Network. So the NCCN is the governing body that decides what chemotherapies are the standard of care, what radiation should be used, what types of surgical techniques should be used, and it's really what insurance companies go to decide if patients are getting the standard of care. So the NCCN expert panel decided that they would create 3 groupings of patients. The first is patients who are classified as being low risk. These are patients who have early stage cancer, who had high baseline physical activity, that is before their diagnosis they were physically active, with no significant comorbid health conditions. And the recommendation for those patients is go out, be active, sit less, build strength, improve your balance. You're free to go, just do what you got to do in order to stay healthy. The second group is moderate risk. These are patients who have peripheral neuropathy. They may have arthritis or musculoskeletal issues. They may have bone metastases, meaning the cancer has spread to the bone, or have poor bone health because of, for other reasons, having osteoporosis, and lymphedema, again, the swelling of the arms and legs that results from surgical excision or irradiation of lymph nodes. And the recommendation for these moderate risk patients are general recommendations for physical activity for cancer with modifications based on your assessment. So for example, I come back to the neuropathy case. If a patient can't feel the bottoms of their feet, it may be best to prescribe a non-weight-bearing aerobic exercise modality to that person, stationary cycling versus walking, where they literally can't feel their feet and they're at risk of having a fall and potentially fracturing something. You should also consider a medical evaluation for these patients, and I encourage you, for those who work regularly with oncology patients, to develop relationships with the oncology providers. Many providers will enthusiastically endorse their patients engaging in exercise, and it's always helpful to have relationships with the providers, because if something happens, you can quickly loop back to help triage whatever may be happening. And third is you should consider referral to a trained rehabilitation specialist, particularly a physiatrist or a physical therapist, particularly if there's a specific impairment that may be amenable to an intervention that may serve as a barrier for them being recreationally physically active. And the third is high risk. So high risk patients are those who had a history of long or major abdominal surgery, those who have an ostomy or an opening in their abdomen to allow them to move their bowels because of the risk of infection, those who have significant cardiopulmonary comorbidities such as COPD, congestive heart failure, coronary artery disease, those who have severe fatigue, ataxia, or really any worsening or changing physical condition. And the recommendation for these patients is medical clearance by a physician, primarily to try to figure out if there's some underlying cause to some of these things. So for example, the fatigue, is the fatigue occurring because they're severely anemic, or is it because they just had, you know, a serious side effect from their cancer therapy that they just need to learn how to manage. So a lot of the referral is really to try to rule out underlying causes of a lot of these symptoms. And again, if there are specific impairments that may be amenable to referral to a physiatrist or physical therapist, again, it's really trying to know what resources are around you, whether it's a psychologist or acupuncturist or a physical therapist, and being able to use them strategically in order to try to dovetail interventions together to try to give the patient the best possible outcome. So last is, a lot of people asking, well, how do you actually implement this in the clinic in real time? So this is a very helpful schema that I'll walk you through that I often use in practice. So when I meet new patients, I often ask them about their exercise history, what they did before their diagnosis. Many patients will say, I didn't do anything. What they've been doing since their diagnosis. Again, a lot of patients will say, haven't been doing much. So the result of that conversation can lead me to two outcomes. They're either meeting the exercise guidelines or they're not. Again, the majority of patients will not be meeting the guidelines. So if they're not meeting the guidelines, my initial exercise prescription for them is often 3 days per week of light intensity, brisk walking, up to about 20 minutes per day. There are some patients that really can't go more than 5 minutes. So it's, you know, 5 minutes or 10 minutes up to about 20 minutes. And I often have them do that for a couple weeks to see how they respond. If they tolerate that well, then I'll increase their exercise from 3 to 5 days a week. I'll increase the intensity to moderate, continue with the same modality, brisk walking or another modality that they like engaging in, and we'll increase time to about 30 minutes per session. If they don't tolerate that, we go back to the prior exercise prescription. We try to figure out what happened. Was it something behaviorally? Are their joints achy? What's going on? And we try to problem solve. If they tolerate the progressive exercise prescription well, there's really two options we then pursue. I either add resistance training, which is 2 to 3 days per week of progressive total body resistance exercise, or I add variation on their aerobic exercise. So sometimes the strength training, they either aren't interested in the strength training despite my best attempts to try to sell them on it, they don't have the resources, or I may think, or we may agree that the aerobic exercise really ought to be the priority for now. And so for those patients, it's often 5 or more days per week. It's moderate, and now adding vigorous exercise, various modalities in order to reduce a lot of the monotony of engaging in exercise, and up to 60 minutes per day. And again, if those titrated doses aren't tolerated, then you just go back to the next lower level and figure out why they weren't tolerated, and then go from there. For those who are meeting the guidelines, we simply provide them with behavioral support, tell them that what they're doing is great for their health. If they have behavioral challenges as time goes, we work with them to try to reduce barriers. If certain toxicities get in the way of them being able to exercise, sometimes we'll tailor their exercise prescription based on what toxicities or adverse events they may have experienced. So really, this is the summary of what I try to roll out in practice on a regular basis with patients. So lastly, these are just some important resources. So as I mentioned, there's not a ton of data in oncology, and often what we fall back on are how we prescribe exercise for healthy adults or older adults, and really the ACSM guidelines for exercise testing and prescription 9th edition really is the backbone for everything that we do. And there is a section on cancer. It's about 4 pages, and it has most of what I just discussed. But that really is the foundation for everything that we do, even though we work with a special population. The paper at the bottom in the middle was the American College of Sports Medicine Expert Roundtable on Exercise and Cancer, and it provided the inaugural exercise recommendations. This was in 2010. The expert panel met last year, and the new guidelines should be coming out within the next 6 to 12 months or so. There's going to be a couple papers that come out of that meeting. The other paper at the middle at the top is the NCCN, the National Comprehensive Cancer Network Guidelines for Survivorship. and one of the chapters in the survivorship is exercise prescription. And on the right is the ACSM Guide to Exercise and Cancer Survivorship. So for those of you who don't know, there actually is an exercise cancer specialist certification through ACSM, and this is the accompanying textbook that goes into a lot of what I talked about in much greater detail, and it basically tells you how to manage these patients and what is the best evidence. This book came out a couple years ago, and given the explosion of exercise oncology, it's, in my opinion, it's starting to become outdated already, which I think is a good thing for the field, but it probably is a helpful resource to give you an understanding of exercise prescription for cancer patients. So in conclusion, cancer therapy causes toxicities that really must be integrated into exercise prescription planning. Exercise induces favorable physiological and psychosocial patient-reported changes in cancer patients. Exercise may prevent recurrence and mortality in cancer patients. We await the results of the phase 3 data from the randomized trial. And exercise professionals like yourselves really should encourage cancer patients to avoid inactivity and work towards the ACSM guidelines. And the mantra that I often use with patients is start low, progress slow, listen to your body. If something starts aching or bothering you, come back, talk to me, we'll figure out what's going on, and we'll make a game plan moving forward. So I'll leave you with this picture. This picture really summarizes my mission, which is, again, to try to understand the benefits of lifestyle, not just exercise, but weight management and diet, and how that can help cancer patients live longer, healthier lives. Thanks, guys.
So we're open for questions right now, and once you ask a question, we need to repeat it so that the folks who are online can actually hear it.
I have 2 questions.
Yeah.
One is, where do you categorize things like yoga, Pilates, those types of exercise that I've had a lot of cancer patients who tolerate that better?
Yeah.
They just don't have the endurance for maybe going for a walk.
Right.
And then 2, where does Medicare stand on paying for exercise therapy for?
So I would classify yoga as neuromuscular. I think it's certainly better than doing nothing. There are data in cancer patients that yoga actually has physiologic benefits, so it reduces cortisol, it can reduce potentially inflammation. I think if patients are interested in yoga, I use that as a starting point to get them to potentially do more in time. So if they're willing to start with yoga, I say, okay, let's start with yoga, and we can revisit this in a month or 2 and see how they're doing. And then I often talk to them about the additional health benefits that they would accrue by doing other types of exercise modalities. With respect to payment, so there are data that if you refer cancer patients to a physical therapist and they're able to find an impairment amenable to intervention, insurance will pay. So when I was at Penn, I was part of a randomized controlled trial that looked at the benefits of weightlifting exercise for women with lymphedema. The primary outcomes papers were published in New England Journal and JAMA. And then the big question became, okay, how do we actually get this to women? And it was discovered that if after cancer surgery, people have all different types of impairments. And if a physical therapist can find an impairment that is amenable to a physical therapy intervention, insurance will often pay for at least a couple sessions for the physical therapist to be able to treat that impairment and also help get a cancer patient on the trajectory of being able to do more exercise. The challenge is there are co-payments associated with going to physical therapy and things like that.
There isn't anything equivalent to like a cardiac rehab type
That's
where you can say this is.
It's one of the big things we're trying to figure out is how to actually implement all these guidelines and all this randomized controlled trial data that we have. There's a lot of thoughts about trying to use existing cardiac rehabilitation resources for cancer patients. And so I think that's, my guess is that within the next decade, we're going to try to figure out how to make this possible. And it's likely going to be multiple different things. It's going to be the silver sneakers at the YMCAs for the lower risk, more ambulatory patients. And it may be something like cardiac rehabilitation, where it's very closely monitored and much more structured for patients that may be a little bit more complicated or have a kind of a challenging constellation of different symptoms. But that's something that we're really trying to figure out, is how do we actually make this happen not just for patients who are treated at large comprehensive cancer centers in the urban area, because the majority of patients that are treated for cancer in the United States are not treated in large academic urban cancer centers that have all the resources. And so it's trying to figure out how can we do something that's scalable so that everybody, even those who are in the Midwest and rural Iowa that drive 2.5 hours to get to their oncologist, can derive some of the benefits of exercise. So there's a lot of interest also in kind of telephone-based interventions to be able to reach patients that are in a little bit more remote geographic areas.
Could you comment on, I believe it's a Live Strong program that's typically at the YMCA's?
Yep.
Is it grant? I mean, I'm not sure how they get that.
Yeah.
Treated patients,
Yeah.
they don't have to be members of the Y.
Right. So the question was the potential role of Live Strong at the YMCA. Yeah. So Live Strong it is now an evidence-based program. There was evidence published a couple years ago by Melinda Irwin, who's at Yale, describing that the Live Strong program, which I think is a 12-week structured program for basically any cancer patients that have access to a YMCA, and it was shown to improve quality of life and reduce fatigue and improve a variety of different other patient-reported outcomes. So I think that's another option. I don't know how gyms fund or support, whether they get some type of grant funding from Live Strong or not. I know that not every YMCA has a Live Strong program, but if you go to the YMCA website in your area, you can figure out what resources they have. And it is, I think that program is similar to some degree as like Silver Sneakers, but it's just tailored a little bit more for cancer survivors or cancer patients.
And that's a strength training component.
Yes, it basically really tries to implement the current physical activity guidelines for all Americans.
So I work in cardiac rehab, and I have a lot of patients that are referred that do have cancer. But I saw how you said like the higher risk patients have other cardiovascular comorbidities.
Mm-hmm.
I find it hard. Of course, I want these patients to exercise, but are like almost hard to make our program work for them. And I don't know how to speak with the cardiologists and say like, hey, they might need something else and not good for our program might
Right.
work for them. It's hard for me to communicate that to them. They just need cardiac treatment.
Right, yeah, so I think that, so the question was kind of the challenges of being able to use cardiac rehab. I think what we're trying to do in oncology is not reinvent the wheel. We're trying to think about what resources exist in a clinical setting already, which for many places is cardiac rehab and diabetes or endocrine, prevention from the diabetes prevention program, the implementation of that. So I think we're trying to think strategically about dovetailing our patients into other existing resources without stepping on people's toes, but recognizing that this patient population may have certain unique needs that are different than a patient with heart failure, than a patient who just had a myocardial infarction. There are probably a lot of things that are similar to those patients, but there are some things that are distinct, and it's really trying to figure out how to harmonize those two things. Also within a hospital setting, to do so in a way that's profitable. That's the other kind of layer that becomes challenging, is how can you do this in a way that is sustainable for the long haul and that also is accessible to patients. It is a delicate balancing act trying to put all those pieces together.
We often see people years after they've had cancer,
Mm-hmm.
their first intervention with them.
Yep.
So I know a lot of the information now is observational, but I guess the basic question is it ever too late to really put exercise in to see some of the benefits or help people with the survival from cancer?
It depends what outcome you're trying to improve. I think to make a broad sweeping statement, probably not. There are potentially some patients where it may not be beneficial to exercise. So for example, there have been concerns raised with patients that are severely cachectic with metastatic pancreas cancer. Do you necessarily want to be exercising them if the calories they burn, they're not consuming back again? And so I think that like with any medical intervention, we have to think very carefully about the tools that we use, because our tools, in my opinion, are really powerful. And I think we prescribe exercise in good faith that we're trying to help patients, but there may be a subset of the population where it's just not the right time and the right place. And I think as we start to push the boundaries in oncology and say, well, let's think about patients that are going to die from metastatic cancer. Would exercise benefit them in some way? I think we have to be mindful about weighing the potential benefits that they derive versus the potential risks that they may be exposing them to. So it's that delicate balancing act. But by and large, for the older adult that had cancer a decade ago, I don't think there's anything wrong with having them exercise. And if particularly if they have long-term symptoms from their treatment, even if it was a decade ago, you now can tell them that there is data to support X, Y, and Z that they may be complaining of. And when I counsel patients that are long out, they say, oh, my doctor told me there was nothing I could do. I just had to learn to live with it. And I tell them that, you know, their data has emerged. This is a rapidly changing field, and we now know that there are certain interventions that may be beneficial, and they might be worth a try, and you should consider. Yeah.
Good question. Good.
Okay.
The first is kind of the efficacy of chemotherapy and that relationship to exercise and maybe some of those settings. The second is I'd love to know some of the biomarkers that you're looking at and what you're finding.
Yep.
Also, maybe adding your thoughts on the third arm, which is sedentary behavior as its own independent risk factor. In the animal.
Okay, chemotherapy. So there's preclinical data in a mouse that mice who have tumors who exercise, it in many cases will actually improve the efficacy of the chemotherapy. And the belief is that it can help to improve the vasculature of the tumor. And many people would say, well, isn't that just delivering more nutrients to the thing that's trying to kill its host? But the reality is, with a better vascularized tumor, you can actually deliver more of the chemotherapy to the target tissue. So that's an area that is now beginning to be translated into human clinical trials. I serve as a scientific advisor to a multi-center randomized trial of weightlifting exercise for patients with colon cancer. And the goal of that study is to see if muscle strengthening exercise during chemotherapy reduces dose-limiting toxicity. So in oncology, if patients have adverse events, we usually dose reduce their chemotherapy, which is associated with worse outcomes. Patients are more likely to recur. So the approach in that study is really to see if we can increase muscle, or at least preserve muscle, an active tissue, so that patients can tolerate their chemotherapy, be less likely to have their dose reduced, and with the belief that we could potentially improve long-term outcomes, in addition from mitigating short-term side effects. The biomarker question. So there's a lot of work related to inflammation. There's a lot of work related to insulin and insulin-like growth factor 1 and their binding proteins. There is emerging interest in immune function, given the popularity of immunotherapy. And there's also a lot of work going on, particularly for certain cancers that are hormone sensitive, prostate cancer, breast cancer, things like that, in certain sex hormones like estrogen and things like that. And the third was the sedentary behavior. Yes, so sedentary behavior is, in observational studies, is a risk factor for developing cancer and dying from cancer. I think that there are ongoing studies to try to understand if breaking up long periods of sedentary behavior improve kind of biomarkers and kind of these intermediate endpoints. The thing that I struggle with is, I think it's really hard to disentangle not engaging in physical activity and engaging in a lot of sedentary behavior. I know there are, in non-cancer populations, there are studies ongoing and some that will be published soon that basically randomize patients to usual care, a group that's asked to do less sedentary behavior, and a group that's actually asked to do exercise, to see what the comparative benefits are, to try to understand, is reducing sedentary behavior really its own intervention, or is it just, you just have to prescribe exercise and the other behavior will follow along? Yeah, that is a very popular area because it's thought to be a little bit of an easier ask of patients to say just sit less versus I want you to walk 30 minutes every day. And I think the goal is to try to figure out how we can initiate a conversation that a patient will say, oh, okay, I'll listen to you versus I'm not interested, leave me alone. Yeah.
Any other questions? Let's check and see if there's anybody online. I don't see any. See any. Any other questions?
How much does depression, anxiety, and other mental health factor into the post-cancer diagnosis exercise program?
With respect to, you mean like their adherence or their willingness to try? So the anxiety, the depression is often driven by fear of recurrence. And I think that, like I said, patients are very motivated to try to understand if there are things that they can do to reduce their risk of having their cancer come back. There are data that patients who are more depressed, who are more anxious, who kind of have poorer overall mental health, they're much less likely to adhere to their exercise program. So the dilemma is those are the patients who would most likely benefit, but they're least likely to do it. So it comes back to trying to understand what tools you have at your disposal. And often for those patients, it's that they really ought to see a psychiatrist or a therapist to learn how to manage a lot of these emotions that they're having. And that could be used as a way to kind of open the door to eventually bridge them to an exercise program. So I think that one can be difficult for many patients who have very mild symptoms. They're often willing to give exercise a try, and a couple weeks later they say, hey, I feel better, I'm going to keep going with this. But for very severely depressed or very severely anxious patients, it's often that they really should see a mental health professional because there are just things that are unmanaged that are really outside the scope of an exercise professional. And I think one of the, particularly in clinical setting, it's knowing kind of what your boundaries are and when you need to pass the baton to somebody else, but also know who is around that you can pass the baton to. And there is very much like exercise, there is very much an explosion of interest in psychiatry in oncology and being able to offer cancer patients mental health services from those that are very mild to those that are severe. So I think it's being able to dovetail both of those interventions together. It would be my recommendation. Yeah.
Okay, thank you very much, Dr. Brown. It's excellent. We have a short break now. There's some coffee at the back there, some snacks. The next speaker will start in about 9 minutes. So you have a few minutes break. Yeah, maybe